Okay, so hi, thank you for inviting me here, Dr. Arsenault. I'm very excited to talk about this topic. But before I get started, I just wanted to start actually with the land acknowledgement first. So I'd like to begin by acknowledging with gratitude that we have the privilege to live and play and today to learn on the unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. Um, I also wanted to just disclose that I have served on the advisory board for Pfizer. My practice is very evidence-based, and I also follow guidelines, and it will have no influence on the current talk. So my name is Caroline Lee. I'm a gynecologist working at the BC Women's Center for Pelvic Pain and Endometriosis. And for those of you who may not know, our center exclusively treats individuals with endometriosis and chronic pelvic pain. And on this slide, are kind of the things that some of my patients hear from their own provider and supports. And it's really distressing to hear statements like this because it really serves to invalidate the experiences that patients may have. And so this may sound very familiar to a lot of people here because you probably have heard similar comments as well. Um, so one of our clinic's focuses is to change the perception of reproductive health, to change the perception that individuals have when they experience pain, and to advocate in that sense as well. And to that end, I'm also here to provide you with the tools to advocate for yourself and for each other too, because I really feel like knowledge is power in a lot of situations. Also note that I'll try to use as gender neutral terms as possible, but there are times where I need to distinguish between male and female, and I may use the word women, but I'm actually referring to women and gender diverse individuals in that situation. So we'll begin by reviewing the menstrual cycle. We'll see how the menstrual cycle influences pain perception. We'll be reviewing perimenopause and menopause and evaluating how these perimenopause and menopause can also impact pain perception as well. So this diagram might be a diagram that's familiar to most, if you've, especially with high school biology, but if it's not, that's okay. We'll go over it in a lot of detail. So when we look at the purpose of the menstrual cycle, the purpose is actually biologically to prepare an individual for pregnancy each and every month. But of course, that's not truly functional in our today's society. And so when we look at the division of the menstrual cycle, it's really determined by the interaction between the brain, the ovaries, and the uterus. And so in the follicular phase, that's the first phase seen here, we see that there is first there's an increase in FSH, which causes or allows for the stimulation of ovulation. So in response to FSH, what we see is that the follicles tend to develop and then you eventually ovulate. And during that time, we also see an increase in estrogen levels and also with the menstrual lining starting to increase in how thick it becomes. The turning point between follicular phase and luteal phase is when ovulation occurs, and ovulation occurs after an LH peak, which is seen in this blue here. And that turns the signal so that the ovary, first of all, releases an egg, but also so that it goes from an estrogen dominant phase to a progesterone dominant phase. And you can see that here where the progesterone levels start to increase. And then progesterone on the actual uterus itself is stabilizes the uterus so that you can sustain a pregnancy. And that'll have an influence, which I'll talk about later. And then what we call the perimenstrual phase is actually very important for pain because that's the period when there is a significant drop in estrogen and progesterone levels, and that encompasses a time to when the period finishes. And so that perimenstrual phase is characterized by low estrogen, low progesterone. The follicular phase is categorized or is classified by its high estrogen, low progesterone. Ovulation is associated with the peak LH levels as we chatted about, and the luteal phase is the high estrogen and high progesterone. And when we look at the way that the menstrual cycle is regulated through what's called the hypothalamic pituitary ovarian axis. And the specifics of what's produced here is not really specifically important, but what we do know is that the menstrual cycle is very susceptible to outside forces, such as stress and that type of thing. And some people actually view the menstrual cycle as a vital sign or like a key measure of health. As a regular cycle, if you have a regular cycle, it indicates that everything is working the way it's supposed to without the influence of outside stress. And what happens with stress is that there's a very similar process that occurs, but with the end result being an elevated level of cortisol, which is that stress hormone produced from the adrenal glands. But what we see is that cortisol impacts the HPO axis at every single level. So at the hypothalamus, the anti-pituitary, and ovaries. And this is very interesting, especially for this population, because we see that chronic fatigue syndrome in particular can be associated with irregular periods or polycystic ovarian syndrome. And we think that part of the reason for that is through the stress mechanism. And so there are several female hormones that we characterize. The most important ones are estrogen and progesterone, but of course there are other hormones that are produced. But we'll go into more detail with these two hormones mostly. So with estrogen, I view estrogen more as that feel-good hormone. So it has an analgesic effect, so it decreases pain perception. Part of the way that it works is that it works through pain inhibition at the level of the brain through the chemical GABA. But also has an influence on the natural opioid system, part of the times at which the opioids are reduced by your own body is during times of exercise or during times of intercourse. So we find that estrogens actually help to enhance this feature, and it also has an anti-inflammatory effect as well. The other thing that it does is it has a growth effect. So it helps with growth of breasts, but also for muscles as well. So what the estrogens do is that during the follicular phase in particular, it increases the availability of fuel for the muscles. And so there's a decreased tendency for lactic acid formation, and there's a longer time to feeling exhausted. And you can see this impact of lactic acid if you were to hold your fist like this for a long period of time. It starts to hurt if you hold it in that position after a long period. And we think that the reason for that is because there's an increase in lactic acid that builds up. But when you're in a state where you have more estrogen on board, that buildup of lactic acid is decreased. And a lot of athletes actually take advantage of this because they tend to work to try to build up muscle during this period, the follicular period. Estrogen also has a heart and brain protective effect, so it tends to favor the good cholesterol profiles and eliminate some of the bad cholesterol profiles. And what that leads to is a decrease in plaque formation on the vessel, so a decreased narrowing of the major blood vessels. And what we see is that we can see this in real life in that men tend to have heart attacks much earlier than women do. And with the average age being, it starts to increase at the age of 40 for men versus 50 for women when people start to go through menopause. And we think that the key factor in that is actually estrogen. And it's very bone protective in that it promotes bone growth, conservation, and this has influences on osteoporosis. So when you have a low level of estrogen, there's an increased tendency for bone thinning. But also, though, estrogen also is known to have an inflammatory effect. And you think that's really against what we know, but it's because there's different mechanisms or receptors on which the estrogen works in different situations. And so in times of chronic stress, what ends up happening is that estrogen enhances that inflammatory response and stress response. And with prolonged exposure to stress, it ends up leading to destruction of normal tissue. And we see that quite often with a condition very dear to my heart called endometriosis, which is where the lining of the uterus grows outside of the uterus. And it grows in what happens is that every time you get your period, you also bleed from those lesions themselves, which leads to inflammation and pain. And so we know that estrogen has a role in this because it causes growth of this tissue. For progesterone, I view progesterone more kind of as an estrogen blocker in some ways. It also is a pregnancy promoter. So when you look at the effects that progesterone has, it has a bit of a slowdown effect on muscles. So it prevents the uterus from contracting. And by doing so, you're able to sustain pregnancies or maintain pregnancies. But then it also has that impact on other muscles, such as the bowels. So there's a bit of a constipation effect that we see, fluid retention. It also has an increased tendency to make you feel like you're more tired than doing the same things as you would have in the follicular phase. And part of the reason for that is because there's an increase in cardiorespiratory strain. And what I mean by that is that there's an increased tendency for the heart rate to go up, to also have increased temperature and breathe more quickly during this time. And finally, there's a negative impact on mood and also on anxiety. And we think that this is majorly caused by the metabolite allopregnanolone, which is a breakdown product of progesterone. And that tends to have an impact on more the brain, and it leads to more negative mood and anxiety during that time. And so premenstrual syndrome is something you probably have heard of. It's more commonly known as PMS because it's a pretty big mouthful. But we know that up to 90% of individuals who have one or more physical or psychiatric symptoms during the luteal phase when the progesterone levels are higher. But these symptoms the symptoms don't impact you to the degree that it has an impact on your daily activities. And premenstrual syndrome is a little bit more of an exaggerated version of this, but still considered normal. And we see that this is seen in about 20 to 30% of individuals. And this is referring to a group of symptoms that occur in a cyclical fashion, so once a month. You have related physical and or mood symptoms occurring in the luteal phase when the progesterone levels are high, and it should start to end by the time your period stops. The most common symptoms are ones that people are often referring to when they're saying I'm PMSing, for example, and it's more irritability, bloating, mood swings, a sense of fatigue, breast tenderness, anxiety, and a feeling of rejection. So you do see that there's a little bit of a retraction effect, so people tend to not go out into social settings as much when this occurs. And things that make the PMS worse are if you have had recent weight gain or stressful events, which can make it into a more pathological condition. And this is a very interesting study that I saw. So this is a study looking at what users of an app called Flow were recording as their daily symptoms. And so this study was meant to capture the experience of the average person who's healthy. And what they had 338 responses. And the Flow apps are kind of interesting because we're seeing in my practice, at least, there's a greater tendency on reliance on these apps. And what's occurring is that people use these apps to predict when they're going to have their next period and when they're going to ovulate, but that also allows you to kind of predict when you're going to have pain symptoms too. So the most common symptoms that individuals at baseline have are food cravings, mood swings, or anxiety and fatigue. But you can see the other symptoms that can occur, which tend to be related to more the progesterone effect. Sorry. Premenstrual dysphoric disorder is an exacerbation of that, or a much more profound presentation of PMS, and it impacts about 2 to 3% of reproductive individuals. And the diagnosis is based on DSM-5 criteria, which is the DSM-5 is the Bible of psychiatric conditions, basically. And this diagnosis is made based on daily symptom tracking over 2 consecutive cycles, at least 2, and they have to be symptomatic cycles. And to make the diagnosis, you need at least 5 of the symptoms in these boxes. And so the blue box is a core symptom. One of them has to be a core emotional symptom, which is it can be mood changes, a sense of anger, depression, and anxiety. And then some of the other symptoms also it all just needs to add up to 5. But if you notice here, there's quite a bit of overlap with chronic fatigue syndrome. And so we'll talk about that later on how the menstrual cycle impacts chronic fatigue syndrome as well. So menstrual cycle and pain. Some of the facts that are very pertinent to the female reproductive system is that there's an increased rate of pain conditions at a rate of 3 to 1 from female to male. And it can increase up to 5 to 1 for conditions such as irritable bowel syndrome. So there's a significant predominance of pain conditions in women and gender diverse individuals compared to men. And this change starts from puberty. And so that suggests that there's a significant influence of reproductive hormones on this process. And you've probably seen a variation of the diagram on the right from Dr. Arsenault, but this diagram is showing a lot of the chronic overlapping pain conditions, of which endometriosis and vulvodynia is what I work with the most. But we see that people who tend to have pain tend to also have irritable bowel syndrome, painful bladder syndrome, and then, of course, with this patient population's fibromyalgia and chronic fatigue syndrome as well. And in those who have the female reproductive hormones, we find that there's a greater tendency for a greater number of pain symptoms. the pain is more intense and it has a greater likelihood of actually impacting your day-to-day function. So it may impact your ability to work, to provide care at home, to carry out your housework. And then, but this has negative consequences as well because there's a greater likelihood of being dismissed by healthcare providers. And what we found is that there's a greater tendency to attribute a lot of the issues that women experience to anxiety or stress. And one of the things that really stood out to me is that there's a greater tendency, for example, with heart attacks for care providers to attribute heart attacks to anxiety and stress rather than making the diagnosis right off the bat. And this is something that really needs to change. And so this is a summary of how the hormones tend to impact pain conditions. We found that generally pain symptoms are the most severe during times of low estrogen. And so that's in the perimenstrual phase. And then during times of rapidly falling levels of estrogen, which you saw with ovulation. And this diagram I thought was a really good summary of all that information. And so what we're seeing is that this level of estrogen, as the estrogen levels increase, we're seeing a corresponding decrease in pain. And then when we see that decline in estrogen level, there's a corresponding increase in pain. And so, this will be reiterated throughout the different pain conditions that we chat about. For fibromyalgia and ME CFS, we find that for fibromyalgia, there's an increased tendency compared to people who don't have fibromyalgia for greater psychological distress and decreased positive affect, so more negative mood. And we think that this is likely related to the progesterone effect. And then there's also an increased tendency for water retention. In the perimenstrual phase, so that time when there's low estrogen and progesterone, they found that pain is perceived as being worse during that time, but when they've done pinprick studies for the different areas impacted with fibromyalgia, there's actually no difference in objective pain measures. And what we think is happening is that people who have fibromyalgia are more likely to have painful periods. And so that leads people to misinterpret some of the fibromyalgia or like the painful periods as being consistent with a fibromyalgia flare. But generally, people tend to feel worse in the perimenstrual and luteal phase. For ME and CFS, there's not as much evidence out there, but what was very interesting to me is that there's a very close link with ME/FS, CFS with endometriosis. And we know that with endometriosis, symptoms tend to be worse in the perimenstrual phase. So we see similar things with CFS. We would anticipate that. But when we look at sleep, we found that in the luteal phase and perimenstrual phase, there actually is a longer duration. Women tend to have a longer duration of sleep, have more deep sleep, and then worse subjective quality of sleep. But when they look at objective measure, they actually find that the sleep quality overall tends to be similar. But what we think is occurring during the luteal phase is that people are needing to go through more of a reparative process during their sleep because there's more of a load on your system during that time. And so you end up feeling like you slept and you haven't slept as well. When we look at musculoskeletal and rheumatological conditions, so autoimmune conditions impacting the joints and other factors, with rheumatoid arthritis, we find that pain tends to be better in the luteal phase when the estrogen levels are higher. There's less joint pain, less morning stiffness. However, there tends to be more flare-ups during the perimenstrual phase when the estrogen levels are low. And so we see that manifest as decreased grip strength and an increase in joint size. For lupus, we find that there's a higher tendency for pain, fatigue, and disease activity during the perimenstrual phase again, probably due to that lack of estrogen as well. And then with chronic back, neck, ankle, and knee pain, greater severity during that expected period as well. For gynecological conditions, these are two conditions that I treat very often. Endometriosis, we know that it worsens around the perimenstrual phase when you have that withdrawal of progesterone. And we know that estrogen causes growth throughout the menstrual cycle. So that has an overall inflammatory effect. For vulvar pain, in those people who have vulvar pain on a regular basis, we notice that the pain tends to worsen around the perimenstrual period, so when the estrogen levels are low, with up to 60% of people describing a worsening of their pain during that time. And again, this is related to the lack of estrogen. For gastrointestinal conditions, we talk about IBS, which is very common, is a common pain condition characterized by abdominal pain and changes in formation of stool. And so in the luteal phase, we find that there's an increased tendency for constipation, and there's a gradual increase in abdominal pain. And we think that's related to the progesterone effect. In the perimenstrual phase, which is when there's a lack of estrogen, there's a tendency for more frequent and looser stool, so a tendency to be closer to diarrhea. And this is when peak abdominal cramping and pain occurs. And part of that might be just because of the lack of estrogen, but we also think that it might be because there's an intimate link between IBS and painful periods. And so it could just be that that's also being exacerbated simultaneously. There is an increased tendency for bloating, so you might hear of the menstrual bloat that people talk about. And then the rectum tends to be more sensitive. So what happens, the rectum is that area right before you have a bowel move where the stool is stored. And we find that it's increased sensitivity to distension. So any stretching would cause you to want to have a bowel movement, for example. For inflammatory bowel disease, this is referring to autoimmune conditions such as ulcerative colitis or Crohn's disease. We find that there's an increased tendency for symptoms during the menstrual cycle, and the most important one of that is diarrhea tends to be most common during that time. Gastroparesis is referring to slowing down of the entire gastrointestinal system, so basically from the esophagus downwards to the rectum. And because of the slowdown effects of progesterone and possibly from estrogen, we see that there's an increased tendency for nausea and early satiety, which means feeling full a lot earlier in the luteal phase as well. For headaches, there's a general trend where when there's times of low estrogen, that there's a high frequency and severity of headaches. For in the mid-luteal phase, there tends to be a lower frequency of headaches and severity of headaches as well. With menstrual migraines, this is the best established relationship to the hormonal fluctuations that are seen and pain. And so what we find is that it's not necessarily the low estrogen levels per se that's causing the headaches to increase, but the rapidly decreasing levels of estrogen lead to a flare-up in migraine headaches during that time. We also tend to see a secondary peak in pain right when ovulation occurs with that drastic fluctuation in estrogen that we saw in that original graph. For temporomandibular pain, we find similar things where there's an increase in pain symptoms in the perimenstrual period. So when the estrogen levels are, where the estrogen levels are low, and during ovulation when the estrogen levels just decline significantly. And for psychiatric conditions, like I said before, the changes are usually attributed to the breakdown product of progesterone. So the elevation and then the rapid changes in that level tend to cause worsening symptoms. And we see that especially with PMDD, of course, that's characterized by sensitivity to that. And also with depression, where we see a worsening mood in the luteal phase to the menstrual phase. And then the other thing is that we see that anxiety and risk of panic attacks tends to increase in the luteal phase to the menstrual phase. And this is very important for us to know too, but particularly with PMDD, where there's a significant response to these hormones, we find that there's an increased tendency for suicide to occur during that time too. So when we see from the mid-luteal phase to early like right before in the menstrual phase, we find that there's an increased susceptibility to suicide then. And so it's really important to know this relationship, especially if you notice your own cyclical symptoms as well. And so what are potential strategies to help with this? This list is not meant to be exhaustive. It's just more, we know that each condition has its own intricacies, but generally the principles are lifestyle changes, which you probably have heard of from Dr. Arsenault's talks as well. But we find that exercise, sleep restoration is key, and dietary changes and stress management are also key. The menstrual cycle does have an influence on pain, as we've seen, but we actually find that the influence of negative mood or depression, anxiety, and stressors tend to have a more significant impact on pain than the fluctuations in the menstrual cycle per se. So it's really important to address those components. For rehabilitation, we find that acupuncture has really there's stronger evidence for endometriosis and painful periods. And so acupuncture is something that we do recommend in those who can't tolerate hormones. and physiotherapy as well. And we also see that there's some evidence for benefit with IBS and painful bladder syndrome. Mood management is also key. So we recommend, as you know, the cornerstone of mood management is cognitive behavioral therapy and mindfulness, but there may be the need for pharmacological agents on top of that. So what that means is antidepressants. And for gynecological management, especially people who are very susceptible to the fluctuations in hormones, the hormonal suppression or hormonal management is, we have the goal of getting a steady state of estrogen and progesterone rather than subjecting individuals to the fluctuating hormones. This is particularly important for people who have menstrual headaches and also for people who have PMDD as well. But of course, this doesn't fit for everyone. And so this is an individual discussion that you'll have with your care provider. And surgical management we'll talk about at a later time. It will be more focused on with my next talk, but there can be some role for surgical management as well. And so we'll move on to menopause. So menopause is, how is it defined? How is it diagnosed? It's actually not a laboratory diagnosis. It's not something that is based on that, but we find that it's a retrospective diagnosis, so made in when you reflect back on what happened. And it's defined by not having a period for over a year, and that being your last period ever. And what we call perimenopause or the menopausal transition is that time frame before the onset of your menopause, and it's usually characterized by menstrual irregularity. And when we look at menopause transition or perimenopause, there's two phases. There's the early phase and the late phase. And the early phase is characterized by by people having very close periods that are very close together initially. And so sometimes people can have periods every 7 days. Sometimes they can have them every 14 days. You can imagine how disruptive that is to your lifestyle. But also with that is what we see with that is that then you go through really rapid changes in your hormones in a very short period of time. And for a late menopause, that's characterized by the cycle starting to space out. So people start to go through this perimenopausal phase first when they start noticing that the periods are closer together. And then later you start to see this widening effect. And so what we see with menopause is that there's an increase in LH and FSH levels. And so doing the LH and FSH levels can give you a clue as to how close you are to menopause. But again, like I said, the diagnosis of menopause is based on based on the lack of a period for a year. But with the increase in LH and FSH, the reason why those levels increase is because your brain is working really hard to try to stimulate estrogen production from the ovaries. And that's not working as the ovaries don't have as many follicles, so you're not able to produce as many the hormones. And so in the menopausal phase, there still is some estrogen that is still circulating in your body, but it's a much weaker estrogen. And this estrogen is derived from the male hormones that are produced from the adrenals that get converted to estrone, a weaker estrogen in fatty tissue. Okay. And so what do you see with the menopausal transition? Often there's a tendency for initially shorter cycles, and then that increases to longer cycles, like I talked about earlier. And you often get very irregular bleeding and also sometimes very heavy bleeding. And so this is a time when gynecologists often may offer a hysterectomy because the bleeding can be so severe that you get to hemoglobin levels that are very dangerous to your health. It also influences the way the bladder and the gynecological organs function. So what we notice is that there's a tendency towards vaginal dryness and then decreased libido, painful intercourse. And the reason for that is there's a lot of different factors, but part of it is that the vagina and the vulva have receptors for estrogen. And when the estrogen is gone, then what ends up happening is that there's a thinning of the lining of the tissue within the vagina and vulva. And so there's an increased tendency for tearing to occur and for trauma to occur. And so, of course, if you have painful intercourse, then you have a decreased libido, and that leads to further dryness. So it can be a negative cycle that can occur. With the bladder, there's also receptors in the bladder for estrogen. And what we start to see is that there can be an increased tendency for urinary incontinence, which is leaking of urine. This is never normal. If you do have issues with incontinence, this is something that there is a solution for. So, but then I think that there's a tendency to avoid getting care for that situation. But anyway, so we find that there's an increase in leaking of urine, either with laughing, coughing, sneezing, or there's an increase in irritability of the bladder. So there's an increased tendency to release urine unexpectedly. And then there's also a significant increase in bladder infection rates as well. And so what we see is that if you start hormone replacement therapy in the vagina, so vulvar, vaginal cream or vulvar cream, it decreases the rate of urinary tract infections by 50%. The symptoms that we consider to be most in line with menopause are the vasomotor symptoms or vasomotor symptoms. So what that encompasses is hot flushes, night sweats, racing heart, so palpitations and dizziness, and that leads to a sense of insomnia and sleep disturbance. And the reason why this seems to occur is because estrogen has an influence on the internal thermostat that individuals have. And when that's dysregulated, then you get these rapid increases in temperature, and then that is associated with the heart racing and that type of thing. And in terms of psychological symptoms, we don't know if it's the lack of estrogen is increasing the risk of depression by itself, or is actually related to the vasomotor symptoms and how it impacts your quality of life. But what we do see is that there's an increased tendency for depression, irritability, and then mood swings, and as well as brain fogging. With brain fogging, in this case being a decrease in memory and then a decrease in ability to concentrate. And other symptoms might be headaches, joint and back pain, dry and itchy skin, weight gain, and then the last component can be bone loss. It's not a symptom, but that's one thing that we always are concerned about, so osteoporosis. With menopause and pain, we find that the overall impact on pain conditions is that there's an increase in pain symptoms with greater age. And then the pain seems to transiently worsen to a great extent during the menopausal transition, as you can see here. And the reason that this seems to happen is because of the rapid fluctuations in hormones that tend to occur, especially in the early menopausal transition. And then that tends to kind of steady out, but still be higher in the postmenopausal phase. And the symptoms that tend to improve actually, though, are cyclical symptoms. So symptoms that are seen with IBS. And then, of course, the painful periods, they tend to resolve with menopause, but other pains tend to worsen. So when we look at fibromyalgia, there's a trend towards a new onset of fibromyalgia symptoms in the menopausal period. With the menopausal period. And for those who have fibromyalgia already, there's a worsening of pain, fatigue, and sleep disruption in the menopausal period as well. This risk seems to increase further if you have gone through surgical menopause, which is defined as removal of the ovaries, both the ovaries, and that leads to an abrupt decrease in estrogen and progesterone levels rather than compared to natural menopause. And what this leads to is that there's a sense of heightened awareness of pain related to vasomotor symptoms. We think it's related to vasomotor symptoms and poor sleep. So there's a greater tendency to have a bit of hyperfocus on pain because of your nervous system being on overdrive due to the vasomotor symptoms. With chronic fatigue syndrome and myalgic encephalitis, what we find is that there's a trend towards earlier menopause in individuals with chronic fatigue syndrome and myalgic encephalitis. And we don't know exactly why that is, but there was an astounding kind of correlation with hysterectomy. So up to 76% of individuals with CFS ME has had a hysterectomy. And we think part of the reason why there's such an increase in risk and in rates of hysterectomies is because this condition tends to be associated with endometriosis. And the relationship was so intimate that they weren't really able to tease out the impact of endometriosis really easily. And so what we tend to see is that endometriosis can impact the ovarian function. So if there's damage to the ovaries from endometriosis, people tend to go through menopause earlier. Hysterectomies can also bring on menopause a bit earlier, even with the ovaries being preserved by about a year. So those factors tend to all work towards causing people to go through menopause earlier than the average population. There also tends to be a worsening of symptoms in the menopausal period, especially if you have surgical menopause, as we talked about earlier, or chemically induced menopause using medications that block you from producing estrogen and progesterone. And because that tends to be worse because there's a sudden drop in the levels. And when we look at sleep, we find that 40 to 60% of women tend to experience insomnia in the perimenopausal period compared to those who are in premenopausal, whereas 25 to 30%. So there's almost a doubling of symptoms during that time. And we think that this sleep disturbance is related to more menopause-related circadian rhythm disturbances. And also because as you get older, there tends to be a natural inclination towards poor sleep with decreased sleep duration, decrease in those restorative REM sleep, that type of thing. For musculoskeletal pain, I found this graph to be very useful for me. And so there was a systematic review meta-analysis, which is basically where they group all the studies on a particular topic and then come to a stronger conclusion based on that. They found that when you look at just the number of people who have musculoskeletal pain, there was a peak from perimenopause to perimenopause, a significant increase. But when you look at perimenopause to postmenopause, this stayed steady. So there was no additional risk of musculoskeletal pain. But when you look at intensity of pain, there's increased in severity of pain. That's almost in a linear fashion from when you go to premenopause to perimenopause to postmenopause. And then there's a SWAN study, which is the study of women's health across the nation. And this was a study that was launched in 1994, and it was conducted across the US at multiple centers. And they enrolled people from when they were age 45 and then looked at how their physical status, social status, and psychological status changed as they went through menopause. And so a lot of research on menopause is derived through this group. But in 2017, this particular study looked at rate of musculoskeletal pain, and they found that 1 in 6 individuals who had gone through menopause had daily aches and pains. So it's very high. And 1 in 6 had pain that was severe to the point that it interfered with work to a moderate level or extreme level. And so when you put those together, there is a conclusion that the decrease in estrogen and progesterone related to menopause may lead to an increase in pain perception. And we don't exactly know what the mechanism for that is, but there may be some relationship to the vasomotor symptoms that tend to occur. So the hot flushes, that type of thing, and poor sleep. For cyclical conditions, we find that for vulvar pain in particular, it tends to increase, and it's for the reasons that we chatted about earlier. So there's a lower lubrication, lower degree of lubrication, higher vaginal discomfort with sexual activity, and a lot of this is related to the thinning of the vulvar and vaginal tissue and related trauma. For endometriosis, we tend to see that there's an increase in symptoms in the perimenopausal period where there's a fluctuating hormones. So symptoms tend to worsen a lot more. And then if you add vasomotor symptoms on top of that, it tends to worsen the already poor quality of life. And then it improves after the fluctuation cedes, once the fluctuations stop. For irritable bowel syndrome, we find that there, of course, is that fluctuation and increase in symptoms during perimenopause. But for IBS, we find that there's a steady decrease in overall symptoms with greater age. And by the time women enter the 7th decade of life, you are approaching numbers that are similar to men. And for men, the number stays steady from the age of 20 to 70. But what does seem to occur more often is that there's a higher chance of gas and excessive flatulence or farting in postmenopausal women. And we also find that surgical menopause, like other conditions, can worsen or initiate some of the symptoms that you get associated with IBS. In most situations, hormone replacement therapy can be helpful, but we find for IBS, it can actually lead to prolongation of symptoms as well. For headaches, we find that there's a worsening of attacks in the early and late phases of the perimenopause, and that's because of the fluctuations that we discussed before. However, there is a reduction in attacks in the postmenopausal period. And this is a recurring theme, but surgical menopause, where we take out the ovaries, is associated with the worsening of migraines, initially at least. For psychiatric conditions, when they look, all the data out there is quite different. So, but the general trend is that it seems that there's an increase in risk of recurrence of major depressive disorder in people who already have had major depressive disorder when they're younger, but not necessarily an increase in new diagnoses. And so overall, what we do see is that the number of people who have symptoms consistent with major depressive disorder tends to increase in the menopausal period compared to premenopause, up to 2 to 4 times higher. And again, is this related to insomnia? Is it related to vasomotor symptoms? It's hard to kind of tease that out. In menopause, again, it's mixed, but there seems to be an increased trend towards anxiety and more major depressive symptoms compared to premenopause. And I like this table because it seems to summarize a lot of the factors that we've chatted about, but major risk factors for worsening symptoms is vasomotor symptoms. So if you have more hot flushes, if you have more sleep disturbance, you have an increased risk of developing depression. If you have a previous history of major depressive disorder, so having that diagnosis when you're younger, it can increase the risk of that. A tendency towards neuroticism, if you've had a stressful life event, such as your partner passing away or something of that nature, it increases. If you have low financial or educational status, and minor risk factors include just that sense of loneliness. So people who have a lack of social support, if they're single or divorced, if they have a negative perception of aging or menopause, worsens it. And of course, a history of PMS or PMDD. Things that tend to protect you from having this exacerbation are really logical. So if you have a healthy lifestyle, you have a lot of supports. And if you're engaging in things like mindfulness and therapy, that tends to be supportive. And menopausal hormonal therapy seems to be helpful for that, which suggests that there is a component of the vasomotor symptoms influencing depression. That's a nice slide to lead into my next slide. But so finally, we'll talk about some management strategies. Again, this is not meant to be comprehensive, but generally the principles are very similar to premenopausal management. With hormone replacement therapy, I think I wanted to just touch base on this. And hormone replacement therapy, it really has a bad rap in the amongst a lot of care providers and also with the general population. And part of the reason for that is because of the Women's Health Initiative that came out years and years ago. And so we're still seeing the impacts of it today. But the Women's Health Initiative, there were a couple of problems with the study, and what they found in that study was that there was an increased rate of heart attacks and strokes, and that ended up leading to decades of women not getting any hormone replacement therapy when they went through menopause. But some of the problems associated with hormone replacement therapy in their study was that they use higher doses than are currently recommended. And then the other factor is that they started the hormone replacement therapy 10, 15 years after menopause had occurred. And in that case, then you've already formed the plaque on the vessels. And of course, in that situation, then you're at an increased risk of heart attacks and strokes because the protective effects of estrogen were already eliminated during that time. And so there is a greater tendency towards moving back to hormone replacement therapy now because it has cardiovascular protective effects. We're thinking it's starting to emerge that is showing that. It has a tendency to decrease the onset of dementia and then also to help with bones and then to control a lot of the vasomotor symptoms that people experience. And so hormone replacement therapy may not necessarily eliminate the pain symptoms that individuals experience, but it is very helpful for improving quality of life. And that is done by decreasing usually the vasomotor symptoms that people experience. So like decreasing hot flashes, night sweats, that type of thing. And the way that is recommended to take the estrogen is to use it through the skin. So the common formulations for that are patches or using a cream or an ointment. And the reason that we recommend that is because this type of formulation gives you more of a steady state of estrogen. Whereas if you take a pill, when you first have the pill enter your system, there's a peak in estrogen that occurs, and then it goes down to the normal level. And so we think that the peak is what is associated with heart attacks and strokes rather than the estrogen per se. So if you keep yourself at a steady level, then we find that that tends to improve quality of life, and it also helps with preventing a lot of the risk factors that people notice. Progesterone, when you're taking estrogen, it's recommended to take it with progesterone if you still have a uterus. And the reason for that is because we know that if you let estrogen kind of act on its own because of that growth effect that we talked about earlier, what can happen is that the lining gets thicker and thicker and thicker, and that can lead to cancer. So progesterone acts against that and keeps the levels of the lining small or thinner. But the natural progesterones actually tend to have fewer impacts on quality of life or on the depression symptoms, and actually helps restore sleep. So we often, even in those people who have had hysterectomies, we tend to combine estrogen and progesterone together. And if you do take progesterone, it's recommended to take it daily rather than cyclically, so that some people do take it 10 to 14 days per month, and then go off of it for the other 14 days. But we find that taking it in a cyclical fashion or can lead to fluctuations in hormone levels, and so it can actually exacerbate some of your pain symptoms. In terms of estrogen for the vulva or vagina, I think from my own practice, I find that one of the most heartbreaking moments is when people go through menopause and no longer are able to share in the intimacy with their partner. And a lot of the reason for that is because of the thinning of tissue that we talked about earlier and associated pain. And so I do view this estrogen as being necessary. We often find that it's necessary for maintaining sexual function, and also to maintain bladder function as well, especially in those who are susceptible to bladder infections. It's often given as a cream or a tablet in the vagina. And I know some of you guys are thinking, why wouldn't the estrogen from the rest of the body target the vagina and vulva? That's not the case. We find that the doses that are given through the skin or as a pill, it doesn't reach the concentration it needs to in the vagina or vulva. And so often I actually add estrogen to the vulva or vagina as a cream. And it's quite safe, even in those people who are afraid of the effects of estrogen. We find that most of the estrogen just stays inside the vagina itself. And so even people who have breast cancer can safely take this. And when I worked at the Vulvar Clinic, we often did that for people who were cancer survivors as well. Other strategies to decrease vasomotor symptoms are here. So antidepressants can be used, and most common ones are venlafaxine, paroxetine, and escitalopram. So they're the different antidepressants that we find helpful. Gabapentin and pregabalin, I'm sure a lot of people from this group are very familiar with that, but it can be helpful for some of those symptoms. And clonidine is a blood pressure medication that can help with symptoms as well. But it's important to know that these strategies are not as effective as hormone replacement therapy, though. Some practical sort of things to help with relief of vasomotor symptoms include, these are pretty logical, but using fans, decreasing the room temperature that you sleep in, layering your clothes, and then consuming cool beverages. And some triggers for hot flushes are alcohol, caffeine, and spicy foods, so all the fun stuff, of course. But if you're able to avoid those, it tends to be associated with a decrease in vasomotor symptoms. And weight loss, exercise, and mindfulness stress reducing techniques also have benefit for hot flushes as well. Okay, so that's really the end of my talk. These are my references. And then I want to thank everyone for your attention here. Okay, so should I just go ahead and look at the questions, Rick, or?
Yeah, you can open up the Q&A on the bottom.
Mhm.
And right now it looks like you have 97 questions
Okay.
in Simon. And so let's try and get through as many as possible. Acknowledge we may not get to all of them.
Okay. So one of the first questions is, can oral micronized progesterone help with pain and other symptoms during the second half of the cycle? We do find that with the progesterone, we find that progesterone actually tends to sometimes worsen some of the symptoms of mood. So I find that that's not my usual go-to for helping with the symptoms. There are instances where I do actually use a little bit of estrogen in the second half of the cycle to help with symptoms, but my go-to is not usually progesterone. And then the next question is, let's see. Okay, so then the next question is, can hormonal birth control help with reducing symptoms? If so, what is recommended? And so the question is whether we should be using the pill, the IUD, or others, and how do you select the right one? I usually recommend against the IUDs to help with symptoms because the IUD tends to have more of a local effect. So 99% of the hormones tend to stay within the uterus. And so you don't get the benefits of suppressing ovulation. In fact, IUDs tend to only suppress ovulation in about 20 to 30% of cases. And so usually if if your aim is to reduce symptoms, then we recommend being on like oral contraceptive pills. So that's a birth control pill. Or the other option is to use a patch or NuvaRing. And if you take it without because usually when you look at the birth control pills, there's a hormone-free interval, and that's when there's no hormones on board, and that's when you would get your period normally. You can actually skip that altogether and just take it steadily and continue on that. And how do you select the right one? It really depends. So if you feel like you're quite someone who's really susceptible to estrogen, then it's better to go with the lower doses because people who are on the higher doses tend to have more nausea. But if you're on the lower doses, it tends to be better. So usually if you're aiming for 30 milligrams, it tends to be the best option, the best of both worlds. Next question is pretty similar. Someone said, when I ovulate regularly, I would have a better week between ovulation and menstruation. Now that I only menstruate every this is really specific to the individual, but does this mean I'm in menopause and I'll get no good weeks ever, or will the hormones balance out? So I think this really depends. It depends on your age. It depends on some of the other factors. Because like I said, sometimes the reason why people might be having irregular cycles is because of stress and how it impacts the nervous system. And that's when we see like that association with chronic fatigue syndrome and PCOS. So it really depends on the individual. I'm not sure if I can answer that to the same level. Oh, and then this question is a really good one. So estrogen is critical to aid in the transport of glucose and the fuel for the brain. Estrogen drops during menopause. So if we were to use hormone replacement therapy to aid after menopause and take outside estrogen, does that make it more likely to have cancer for the breast? And what is the science? And so with the science behind that is that the levels that we use are very low levels. So with the estrogen alone, there actually is less risk of breast cancer. We actually think it's progesterone that causes more of an increase in rates of breast cancer. And the rate tends to increase more often when you're taking it in more of a cyclical fashion. And so they've done extensive studies on breast cancer because breast cancer is so ubiquitous with a rate of 1 in 8. And we found that if you limit the level of hormone replacement therapy to 10 years, the risk of breast cancer does not increase, but it may increase after 10 years. If you're in postmenopause, can estrogen help with the pain? That might not necessarily help with the pain per se, but what we do notice is that it tends to help with quality of life. So if you're not having the hot flushes and your mood is better, you're sleeping better, then your pain tends to feel like it's better as well. What is the effect of hormones with laxity and ligaments? And this is a really good question too. This person says that they find that there are certain times in the month where they're prone to neck and posturopelvic or thoracic instability challenges. And so we can kind of derive some of the literature from what happens with pregnancy when that's a really high progesterone state. And we do know that high states where you have more progesterone, so probably the luteal phase, you tend to have more pain during that time and more ligament laxity during that time. But we don't tend to see those effects as much or to a greater extent until as like you would see with pregnancy. Okay, and then this person says, I have endometriosis, I'm going through perimenopause. Should my endometriosis get better as the menstrual cycle stops? We do find that that is the case. And so we do find that the symptoms tend to worsen around perimenopause, but it tends to improve after menopause. And then someone said, can you still experience PMS when you're on birth control pills? That is still possible. We find that birth control pills, when you withdraw the estrogen and progesterone, can be a time when you have more symptoms. But also the progesterone by itself in the birth control pills can independently cause issues with depression. And so it's a matter of finding the right progesterone for you. Um, so this one person said, I have had a partial hysterectomy, removal of one uterus, one ovary, and I still feel like I have PMS symptoms, breast sensitivity, pain in the areas of the ovaries. Is this real? It is real. Because even though your uterus is gone, it doesn't mean that the ovaries are not still working. So your ovaries still go through the same process where the hormones tend to fluctuate on a cyclical fashion. So I always tell people when I'm doing a hysterectomy that I can get rid of the pain associated with the uterus, but I can't get rid of symptoms that you might have associated with PMS because you're still cycling during that time. Yeah. Someone was wondering if we could just go over how endometriosis feels. Um, they said that they have severe pain in the back and gut area, feels like a ripping inside. So the most common symptom with endometriosis is severe painful periods, and it's severe to the point that it causes a disruption in your quality of life. So you're not able to carry out with work or with school, for example. That's my number one hint, but other associated symptoms can be deep pain with intercourse and pain with bowel movements as well. And so the general, like we'll talk about this later at a different point, but the theme that we typically see is that people go have their first period ever, the pain is very severe, and then it can become a daily pelvic pain if it's left unchecked. So there's questions about menopause and an individual who has ME, CFS, fibromyalgia, and POTS. We generally tend to see that and how things change with menopause. We often see that symptoms tend to worsen after menopause because of the low estrogen level. And so we think that the low estrogen level is what leads to vasomotor symptoms. So what that means is hot flushes and the sleep intolerant, like the sleep issues, that type of thing. And that state where you have the fluctuating levels of levels of like temperature can actually worsen a lot of symptoms associated with ME and chronic and fibromyalgia. And someone that talked about long COVID and irregular periods. We haven't noticed, like, I think there could be a link with this. So, like I talked about earlier, we know that times of stress, like when a body is going through chronic stress, there's a greater tendency for irregular periods. So it's probably similar to how chronic fatigue syndrome can lead to irregular periods as well. So we've actually found that so I think that there is a potential link, but it's a little bit too early to say like for sure how COVID affects your menstrual cycle. And also like the other thing that we see with the menstrual cycle is that with COVID is that having COVID tends to cause a change in the way your menstrual cycle functions. So I often notice a worsening of pain during that time when you have COVID. But this is kind of based on my observations rather than data. Um, Someone is on progesterone for the management of severe hot flushes. It doesn't seem to be working as well. Is this possible? I find that progesterone by itself for hot flushes does not tend to be the most effective. I often find that estrogen is the more useful component. So I don't tend to prescribe progesterone alone for management of hot flushes, but that could be appropriate for people who have estrogen receptor positive breast cancer, that type of thing. So with people who have had hysterectomies or uterine ablation and are going through menopause, how do you know if you've gone through menopause if you don't have a period? That's a very good question. You don't ever truly know, and so in that situation, I would recommend doing hormonal testing. And so like the most common thing is that you might start noticing that your cyclical symptoms don't occur as often. So one thing I like to track is a lot of people have breast tenderness at certain times. And so if you're still noticing that you're getting breast tenderness once a month or so, then that might indicate that you're still not in menopause yet. But this is a situation where lab testing can be helpful. If our family doctor is not knowledgeable, how do we see someone like you for hormone supplementation or endometriosis? Our clinic does limit the referrals. So we do see people after they've seen a gynecologist, but I would say that the first step would be to advocate for a gynecology consult in that situation. And we are also working on our end to try to increase knowledge that is provided to family doctors as well. But we do know there's a lot of work to be done because we know that the average rate of dismissal or like the average rate of diagnosis delay for endometriosis is 4 to 11 years. So what I would suggest in this situation is to try to get a gynecology consult first. I'm gonna ask what causes spotting days before your period. Sometimes we think that the days before the period, the reason for that spotting is because you have that withdrawal of progesterone. So the lack of progesterone leads to you starting that process to shedding your period, so shedding your menstrual lining, and so that's what causes spotting right beforehand. Does bioidentical hormone replacement therapy help with symptoms of CFS FM in addition to supporting perimenopause and other menstrual cycle function? Um, so we do like the estrogen and progesterone that we use are bioidentical hormones, so it is the same composition as what your body would normally produce. For bioidentical hormones, though, there's some caution with that because the estrogen tends to be effective, but the progesterone that is prescribed doesn't tend to be absorbed well through the skin. And so we have actually seen an increase in incidence of endometrial cancer with bioidentical hormones because there's no counteracting component to that. So I think that if you have no uterus, then it might be a reasonable option to do bioidentical hormone replacement therapy. But if you do have a uterus, I would exercise some caution in that situation. Do ferritin and hemoglobin stores get impacted by the cycle? Of course it does. So because especially people who have really heavy cycles, we see that there's a significant drop in ferritin levels and hemoglobin, especially around the menstrual cycle. And so the most common reason for anemia in people with reproductive age is heavy menstrual cycles. Treatment for incontinence. What is the treatment for incontinence that you alluded to? So the first treatment is actually pelvic floor physiotherapy, and the goal is to strengthen the muscles, and that's first line. If there's no improvement with that, it would be to see a gynecologist or a urogynecologist. That's someone who specializes in the bladder and the gynecological system. And they can do a test to see what type of incontinence you have, and that will determine what type of treatment you would seek. So if it's because you have a very irritable bladder, it may be medication or retraining of the bladder. If you have incontinence where it's due to the position of the urethra, the opening of where you pee from, then you might benefit more from surgery in that situation. Can you get cold flashes as well as hot flashes? That's a really good question. So what often happens is like hot flashes is sometimes a misnomer. And so what happens is that people get these hot flashes, they get these night sweats, and then they feel really cold because then they're covered in sweat. And so as that sweat cools, then you start to feel really cold as well. So yes, you can get both hot flashes and cold flashes. When someone has had a full hysterectomy and cervix removal, can topical estrogen help with the bladder? Yes, it can, definitely does. We find that if you use estrogyn or one of the estrogens that are administered through the vagina, it really helps with the bladder too. But you usually can also use that in combination with pelvic floor physiotherapy as well. Do menstrual migraines stop or improve with menopause? We do generally see that. Times when it doesn't happen is if you went through surgical menopause, and that tends to worsen the symptoms. Do you recommend taking Vizan for endometriosis? I do. That's one of the most commonly prescribed medications for endometriosis, and it is reliable to take long term. We usually you can actually take it until the age of menopause, but the impact it can have is that your bones may not be as strong. So we do recommend some testing for that. So it might be bone mineral density testing and making sure that you take enough calcium, vitamin D, and weight-bearing exercise if possible. And so someone was asking about hormonal suppression as treatment for menstrual migraines, and how do you achieve hormonal suppression? If it involves giving hormones, how do you treat people who get migraines with aura, which are contraindications for estrogen? This is a really good question. So the reason why we give birth control pills is because it gives you a steady state of hormones rather than that fluctuation. And we think that it's the rapid changes in estrogen levels that are associated with with worsening migraine headaches. And so in people who have auras, though, estrogen is a contraindication because it can increase the risk of strokes. But in that situation, we actually tend to use just progesterone only pills. And so if you're able to get away with just using the lower dose progesterones, we find that to be much more effective. And then it won't have an impact on your natural estrogen levels to the same extent. What is considered early menopause? So early menopause is if you've gone through menopause before the age of 40, or 40 or less, and that has significant impacts. And that's one situation where we definitely recommend hormone replacement therapy. Can perimenopause or menopause lead to misdiagnoses? It can. I think that we find that. So can you be diagnosed with sleep apnea or other conditions? Sleep apnea, not so much, but it may be that you have restless leg syndrome. You may be diagnosed with, for example, restless leg syndrome, but it's actually perimenopause and the hot flushes, sleep disturbance that's leading to the symptoms rather than the condition itself. Are there any supplements or dietary recommendations to help reduce various symptoms? There's various handouts on anti-inflammatory diets, and that's something we do recommend. And so our website has a handout on what's considered an anti-inflammatory diet, and if you refer to that, we find that there can be some relief of some of the symptoms. What's my view on hormonal contraception that reduces the frequency of or eliminates periods? Is there any evidence that these have a positive impact on people with chronic pain conditions? My view is that it's beneficial. So I think that a lot of people don't realize that. So previously, before we went into modern society, what would happen is that people would go through their first period ever when they're maybe age 12, 13. They would get pregnant shortly after, and then they would not have no periods during that time. And then they would be breastfeeding for 18 months or so. have no periods during that time, and then they would get pregnant again. So what we're seeing is that there's a significant increase in the level of pelvic pain conditions that's arising as time goes on and as people are not having children. And we think that part of the reason is because people are having so many more periods compared to what happened previously. So some of the numbers that we've seen is that before, people might have had 40, 50 periods in their lifetime compared to 400 to 500 periods that we're experiencing now. And so when you have more monthly triggers that may cause pain every month, then you're more likely to develop chronic pain. And so in that situation where you have chronic pain, we do find that being on hormone replacement or hormone therapy, hormonal contraceptions is beneficial in that situation. What age is earlier when you say that those with ME or CFS go through menopause earlier? So the number is usually 42, 43 compared to age 51. Is it true that getting your menopause is related to how early or late you had your period? We haven't found any relationship with when you went through your first period ever, but there is a relationship to the age that your mother went through menopause for sure. So if there is a family history of people going through menopause early, then we can reasonably expect that you'd go through menopause early as well. This question is, I have ME, CFS, and endometriosis, and I take birth control pills continuously to manage the endo. I also think I am in perimenopause. I'd like to look into other options and also find out about hormone replacement therapy options for the future. My GP is supportive, but not very helpful. Who can I get referred to for better care in this regard? This is kind of the bread and butter of most gynecologists, so I'd recommend seeing a gynecologist. If you're specifically looking at hormone replacement therapy, there are individuals who specialize in menopause, in menopause in particular. And so there's Timothy Rowe is one person that specializes in menopause. A lot of people like going to, but I would say that the average gynecologist would be able to handle any questions with HRT. This next question is, what is the average age of menopause in the general population? The average age is 51. How does taking birth control pill to regulate your hormones and cycle impact perimenopause and menopause? If you're taking birth control pills, you may not realize that you're in menopause until you go off of the medication. How it doesn't impact though, like how early or late you go through menopause. It just is that once you go off of it, you would know whether or not you're in menopause. If we suspect perimenopause may be impacting our pain level, are we able to get labs to check that? If so, what can we ask our family doctor for? How long will the results be relevant considering the cyclical nature of this? The labs that we see are only valid for that cycle that you're on, but if it's important to make sure that you time the labs at the right time. So we usually recommend day 3 of your cycle, and you would undergo LH, FSH, and estradiol levels at that time to see what your current state is. And you can ask your family doctor for that. So if one is on only estrogen from early menopause, how would that affect pain perception as compared to being treated with both estrogen and progesterone? It probably won't make a huge difference, but we do find that the natural progesterones tend to restore sleep a bit better. So but it's not wrong to also just be on estrogen by itself. What are solutions for hormone positive cancer survivors who are in early medical menopause? Some of the solutions is like the vaginal and vulvar estrogen tends to be helpful in that situation, but it won't deal with a lot of them vasomotor symptoms that you may be experiencing. And so in that situation, what we recommend is a lot of the lifestyle changes that we chatted about earlier. And then the other things that can be helpful is antidepressants like venlafaxine, taking something like paroxetine or escitalopram. Those are all antidepressants. We find that gabapentin and pregabalin can also be helpful, and clonidine as well. Someone says they're 55 and unaware of where in menopause they are, given a hysterectomy and oophorectomy in their 40s. They have multiple diagnoses and their GP will not prescribe estrogen, as I've never had a hot flush. Given what I've said about estrogen, shouldn't it be given to those with these diagnoses to improve pain and decrease osteo and potential for heart issues? I would agree with that. I don't think that there's significant harm. So we say that as long as you're under the age of 60, it's safe to start estrogen. So I would recommend taking estrogen in that situation. Someone asked about trends and conditions and symptoms during the hormonal changes of pregnancy and breastfeeding. So pregnancy is associated with a high level of progesterone and estrogen. And so we often see that during pregnancy, there tends to be a bit of quieting of autoimmune conditions and pain tends to improve during that time. But you would get an increase in musculoskeletal pain. So because of the imbalance from the larger belly, we see that people are more likely to develop back pain, sciatica, that type of thing. With breastfeeding is associated with a low level of estrogen, similar to menopause. So I often find that people actually get worsening of chronic fatigue syndrome and also with like worsening of pain during that time, similar to menopause too. So there's a question about people who are BRCA positive and wanting to, with a history of past history of breast cancer. Um, we, and whether or not we should be using hormone replacement therapy, but in modified doses. I think that it's a risk benefit sort of thing. So it's if you're negative for all receptors, it's unlikely to cause this increase in it. You might not be able to find someone who'd be willing to provide that care though. So I think that like if overall, I think there's some people who decide that the quality of life is more important than the small possibility of there being an increase in breast cancer. And in that situation, then I would be more willing to prescribe progesterone or sorry, the HRT in that situation. And if you specifically like with the people who have a history of breast cancer, there tends to be a gynecologist who specializes in all this associated with the clinic. So I'd recommend that you reach out to those clinics and you can have a very informed conversation about hormone replacement therapy in that situation. Um, Now, what are the benefits and disadvantages to continuing HRT years after menopause? When should it be stopped? Will the pain levels increase when or if it is stopped? Great question. So benefits of continuing is that it's going to continue to sustain a lot of the moods, it's going to prevent a lot of the vasomotor symptoms. And then it's also going to help with bone protection and heart protection. But there really isn't enough knowledge about being on hormone replacement therapy past the 10 years right now at this stage to recommend when to stop it. The current guideline is that we should stop it after 10 years, but I suspect that this will change with time, but we don't know the evidence for that yet. When you do stop the HRT, your symptoms likely will increase at that point, but most people will recommend going off of the hormone replacement therapy at that point because there's not enough evidence. Some of the reasons why people are hesitant to continue it past the 10 years is because of the increase in risk of breast cancer that might be seen, and also because there can be an increase in risk of heart attacks and strokes, but we haven't really seen that play out in real life yet. What about 15 years post-menopause? In that case, I would say that most people would recommend not starting hormone replacement therapy because estrogen, like I said, the lack of estrogen can increase the level of plaque that forms on the blood vessels. So in this situation, it's more risky. So I don't think that you'll be able to find anyone who will start hormone replacement therapy. Can I get a referral to me for management of PCOS? So PCOS is not something that I manage on a regular basis. So it's more that I treat endometriosis and chronic pelvic pain. So I'll talk about the referral criteria for my clinic later. This question is, what would you recommend to someone who cannot take estrogens, that they're on blood thinners for life due to pulmonary embolism? A lot of the non-hormonal medication that we talked about before can be helpful, and there can be some benefit with just progesterone alone in this situation too. So that would be prometrium or the natural progesterones. What numbers on blood tests would indicate if a person would be a good candidate for hormone replacement therapy? Would hormone replacement therapy reduce many of the symptoms? Any potential side effects? Would one have to see a ObGyn for correct dosages? And lastly, how cost effective is it? There's no number on blood tests that would tell you whether or not you would be a good candidate. We base it off of symptoms. HRT will likely reduce a lot of the symptoms that are mentioned, and side effects tend to be very minimal with this because your body used to produce a lot higher levels. And then you don't need to necessarily see an ObGyn to get the correct dosages. You can, if a family physician feels comfortable doing so, then I think that's reasonable. And I'm not sure about what you mean by cost effectiveness, but we find that overall it tends to have more benefit than risk. So can a woman start hormone replacement therapy before the onset of menopause to help with fatigue and or pain? Yes, that is the case. You can actually start just estrogen alone as long as you're cycling regularly. I have done that in situations where people have a lot of the vasomotor symptoms. So you don't have to necessarily meet the criteria for menopause to have hormone replacement therapy. Does coffee need to be avoided all day or just night? Generally, I think the overall message is for coffee to be avoided in general, but it's like, I don't think that's realistic, to be honest. So what I would recommend is just avoiding it at night, taking the first drink in the morning, and then limiting it for the rest of the day is what I would recommend. Can you comment on the role of exogenous testosterone for pain in menopause? Exogenous testosterone doesn't seem to overall improve pain, but what it can help with is actually restoring libido and also like energy, that sort of thing. So it has a bit of an indirect effect in that it improves your quality of life, but not necessarily improves pain. Have you heard of CBT for night sweats? What's your opinion on it? We actually find that CBT can be helpful for night sweats. It just hasn't been studied well enough yet to make a strong recommendation on it, but it definitely is helpful for insomnia associated with night sweats. And I think that if you have the ability to do so, I would go ahead with CBT. Will pain sensitivity, muscle pain, brain fog, depression, anxiety improve after menopause, or is this forever? Eventually, we do find that even if you don't take hormone replacement therapy, individuals will have decreasing severity of their vasomotor symptoms. And at that time, the pain sensitivity, depression, anxiety may improve. Muscle pain tends to worsen with time, though. So I think you have to look for alternative strategies to help with that pain. One person says they're 37 and they have premature ovarian failure. Would hormone replacement therapy be suitable? I would definitely recommend hormone replacement therapy in that situation. I would start right away for that. If an individual had a hysterectomy and is only on 1 milligram of estrogen by tablet and having sleep, pain, or mood symptoms, should they discuss an increase in estrogen through a patch as a better option? I would say so. It's always better to go with a patch or a gel over the tablets, and there are different doses that are available out there. How does the hormonal cycle affect back pain? I notice more back pain during PMS and menstruation and ovulation. I also have fibromyalgia and notice pain perception heightens in these phases of my cycle as well. So hormonal cycle, we find that often the pain tends to worsen around times of fluctuation. So if you're noticing pain during the PMS and menstrual period, that's because of the sudden drop in estrogen. And if you're noticing increase in pain during ovulation, again, that's related to the drop in estrogen. Periods by themselves can cause back pain too, because a lot of the pain tends to be referred back to the back. And we actually notice this in people who have back labor when they're pregnant and laboring as well. Can you still get pregnant in the beginning stages of premenopause, and can you still get pregnant if you get hormone replacement therapy for night sweats? You can definitely get pregnant in the beginning stages of premenopause. There actually is an increased tendency for twins or multiples in that situation because your brain is working so hard to try to stimulate growth in the ovaries. So, and you can still get pregnant with HRT. We find that with HRT, the levels are never to the point that it would suppress any natural periods. And so there definitely is a chance of that as well. I have fibromyalgia and I do have temperature fluctuations in or at least my body seems to be bad at regulating its temperature. Would estrogen help with that? It likely will. My blood work showed abnormally low levels of LH and FSH, which I found strange, especially considering my age, 30 at that time. My OBGYN told me not to worry about it. So what that means is that you can see low FSH and LH levels when you're really stressed because it tends to inhibit those levels. But okay, do you need me to stop?
We're just at the end. Thank you for a fantastic presentation, and we look forward to seeing you in a couple weeks.
Okay, thank you.
Bye, everybody.